Hi, I'm Nick Lologis, an infertility specialist, and I'm here to tell you about a journey. This is a journey that lots of infertility patients undertake. The journey means that the couple have decided they need to go down the IVF pathway, and I'm going to talk to you about the steps involved in going down that pathway. There's an umbrella in Melbourne called the Artificial Reproductive Technology umbrella, which has two arms to it. The first is to do IVF, the second is to do IUI. IVF stands for in vitro fertilisation, IUI stands for intrauterine insemination. It's funny that in vitro really means glass, but we just use plastic now, there's no glass involved. So I think that this journey is a wonderful journey for those couples who have struggled to achieve a pregnancy in the natural way, or with fertility tablets, or with timed intercourse, and it'll achieve the goal, the dream of producing a baby and commencing your family. The whole process is very safe, and I'll just go through what a patient has to do to achieve their goal. Well, your journey has finally brought you to an infertility specialist. There are lots in Melbourne, and they'll all be able to help you. But before you make that final decision, you need to know your options. And I always tell my patients that they don't have to have a baby. You could be childless and enjoy life. Sleep in on a Sunday, travel outside of school holidays, no school fees, no squabbling about the inheritance, have a root in any room of the house and scream as much as you like, walk around naked. There are some advantages about that. So the second option is that you could try for adoption. You contact the Department of Human Services, but you'll find that can take 4 to 7 years, and they don't like you having infertility treatment while you're applying for adoption. The third option, and it's the option that most people follow when they come to see me, is to use their own eggs and milk, sperm, and that's the one that we encourage, unless they've had multiple cycles of IVF and they've had no success. The fourth item is to use donor eggs or milk or sperm, and that helps couples that struggle to make eggs and struggle to produce quality semen. And finally, the fifth option is to use surplus embryos from other couples. And I can tell you that that works, and I've got 2 of my own patients who've gone to Chattanooga, of all places, to have embryos donated to them, and they both conceived. So that is a viable option to think about. Say you've decided to do IVF. Now it comes under the umbrella of Artificial Reproductive Technologies, ART, and under that umbrella there are 2 arms. We can put your husband's sperm directly into the uterus at the appropriate time, releasing the eggs so that they're there to be fertilised, or we can, that's called IUI, or we can collect the eggs and inseminate them with your husband's sperm and grow the embryo out to day 5 and transfer it then either fresh or frozen. So it sounds involved, but let me just take you through a classic cycle that most of my patients go through. We need to get the eggs. So to do that, we inject you with a drug called follicle stimulating hormone, and that grows the egg. We monitor the growth of the egg with ultrasound so that we know when the egg will be ready and ripe to collect. We like to get between 5 and 15 eggs per patient. Now, not everybody's the same, so we might get 8 in one or 20 in another, but we aim to get around 5 to 15. This means that we will have, at the end of the day, embryos. This is where we put the sperm into the egg and they fertilise, that we can grow out to day 5. So the classic cycle is your period starts, we start the FSH, which is the drug that makes the eggs grow. On day 8 or 9 of the cycle, we do an ultrasound to see how many eggs you have. In line with this, you'll be taking another drug, either a spray or an injection, depending on what cycle the doctor has decided to give you that will stop the eggs from being prematurely released. Once we decide to collect the eggs, you are given a drug called the trigger injection. That sounds good, doesn't it? It sounds like a horse galloping down the main straight. But trigger is given, and 36 hours later, we take you to theatre. You have a very light anaesthetic, so you feel nothing. You're put to sleep, and then very gently the doctor will pass a needle up through your vagina, and the vagina is very close to the ovary. 2 to 4 millimetres separate the top of the vagina from the ovary. And this needle passes into the ovary, and we can see the picture of the ovary on the ultrasound screen. So we know exactly where all the follicles are and where all the eggs are. So we drain all these follicles, and in the fluid that comes out of them is hopefully the egg. The fluid goes into a tube, it goes into the laboratory where the embryologist looks at the fluid and screams through the little window, 2 eggs in this tube or 3 eggs, and we tally them up, and at the end of the small operation we'll know how many eggs have been collected. The eggs are then cleaned, not that they're dirty, but we have to make sure they're mature. And then we get the semen or the milk from the husband, and we select out the best sperm, which are usually injected into the egg. And we do this under a big microscope, and it's called microinjection, or ICSI, intracytoplasmic sperm injection. You don't have to be worried about the terms. It's just that we put a sperm into the egg. It usually fertilises within 24 hours, and then we watch it grow. And we grow it out to 5 days. That's called the blastocyst. And this is what happens in nature. It is the blastocyst that comes into the uterine cavity, or to the uterus, the womb, the oven, and that's when it implants. So if we can transfer an embryo that is a day 5 embryo, you have a much better chance of achieving a pregnancy. We used to transfer them at day 3 in the old days. What's even better is that if we test the embryo, this testing, which is called pre-implantation genetic screening, will pick out the normal embryos. If you have a normal embryo transferred into the uterus, it doubles your chance of a pregnancy. In other words, if you're quoted 30%, it'll go to 60% because you're transferring a normal embryo. And this is a fantastic advance in the way we manage our patients. Yes, it does mean that it takes a little bit longer, and we know that everybody wants to have everything done yesterday, and that's the modern society we live in. But with patience, you will achieve your goal. And I'm seeing this with my patients, that if you do transfer normal embryos, it is fantastic. Now, some patients don't want to go down the IVF pathway like that. They want something more natural. So the other arm is called intrauterine insemination. So what happens, we give you the same drugs to grow the eggs, but not in such a high dose. So we get 2 or 3 eggs. Then we release the eggs. We prepare the husband's sperm or milk in the laboratory. And about 40 hours after we release the eggs, we inject the sperm into the uterus. In other words, we bring the milk, the sperm, closer to the egg. Remember, the egg is sitting in the tube waiting for that sperm to get to it. And that has a success rate, which is not as good as IVF, but there are some couples who achieve pregnancies doing that method. So at the end of the day, you'll have your first cycle, and you may have some wonderful embryos that have been tested and are normal, and that might be your entire family. You'll have a frozen embryo transfer, and we wait to see what the result is. When you have a frozen embryo transfer, we can do it either in a natural cycle. In other words, we monitor your cycle to see when you are going to release your own egg, and then 7 days later we put the embryo back into the uterus. Some patients, unfortunately, don't have a regular period, so for those patients we give them a medicated cycle. This is where we give them hormones to prepare the lining of the uterus, the oven, for implantation. And after 5 days of progesterone, which is a hormone to make the lining of the uterus very, very juicy and ready for the embryo to implant, we put the embryo back. Overall, the success rate is very high in our clinic. We quote 30% to 35% for all our patients, but that's usually a percentage for untested embryos. In a couple of years' time, that will be much higher because we will only be transferring normal embryos that have been tested. So that's your journey. The journey is frightening in a little way because you think about all the injections you'll have to have and the anaesthetic. But when the patient goes through this cycle, they say, well, that wasn't too bad, doctor. And apart from those women that have an aversion to injections, they all pass through it very, very easily. The complications, well, the biggest one is if we overstimulate you. We don't want to do that. So we take great care in the dose of the drug we use and the type of stimulation we use. But if you were to be overstimulated, nobody has died from this, nobody has suffered any major problems from this, but we have to manage you usually in hospital. The only other complication is if you were to develop an infection from us putting a needle up through your vagina into the abdomen to retrieve the eggs. Very rare. 1 in 10,000 women will have this happen to them. So overall, it's a very safe procedure. It's something that you need to think about seriously if you've been trying for a baby and it hasn't happened. And don't be frightened by it. It's a very, very common procedure now performed around the world. The clinic that I use has had over 20,000 babies born. There's no harm to the babies. There are no defects. There's no abnormalities. The kids are normal. So you should be very, very positive in your attitude if the doctor says to you, you need IVF.